arena after starting out in the coronary care unit and knowing that I wanted to move to the area of prevention, both in the outpatient clinic and in the cardiac rehab arena. And I'd like to say that nursing can be an advocate for patients, both in getting the tests they need, assessing their risk, and helping them with lifestyle management. I'm also very involved with the Preventive Cardiovascular Nurses Association. I'm a founding member and on the board. And we are a professional organization that is dedicated to advancing the role of nursing, collaborating with our physician colleagues in enhancing risk factor modification and lifestyle management. The coronary artery calcium test is a very important test, I believe, in advancing this goal. I've been in the trenches fighting with insurance companies to get authorizations for these tests when the costs were extremely high. And I'm very excited that people are here today to listen to the current data, the current results, and hopefully we'll move toward making this a test that is now covered for all of the eligible patients in California.
I'm Morteza Naghavi. I'm the founder of SHAPE, Society for Heart Attack Prevention Eradication. The entry to this field for me was from my time at Texas Heart Institute about 15 years ago, when the field of vulnerable plaque was evolving. And so I started vulnerableplaque.org, became vulnerable patient through a guideline, a consensus paper that I led along with Jim Willerson. And the whole idea was that vulnerable plaque is a plaque, tiny plaque that has the tendency to rupture, you saw in that video. It can only be detected if you have a catheter into the coronary. And you can't put normal people, asymptomatic people, in cath lab to put catheter in there. So I started looking to go beyond cath lab and looking into non-invasive detection. Unlike Dr. Berman and Dr. Budoff, I don't practice coronary calcium or imaging. I didn't have any expertise, so I went out and reached out to all the expertise that were out there. Dr. Agustin, who started this field, everybody lent their support, so we created the SHAPE guideline. SHAPE at that time was screening for heart attack prevention and eradication. I emphasize on eradication. We can eradicate heart attack. It's not like cancer, where the folks at Hopkins published a fantastic paper, it's 70% by bad luck. Heart attack is not a bad luck. It's an event that is brewing and brewing and brewing and suddenly surfaces. We have now tools, unlike Framingham's study time 40, 50 years ago, where we guessed based on cholesterol. We have a tool that looks into the arteries, detects. If you don't have calcium, you're really lucky. Especially if you're 50, 60-year-old and your calcium is 0, you are lucky. But if you have calcium, it's not the end of the world. We have treatments, and we can do something about it. So the SHAPE guideline, screening for heart attack prevention and eradication, took a lot of publicity and notice, and we changed our organization's name to SHAPE, as Society for Heart Attack Prevention and Eradication. As this publicity happened, one day I got a call from a congressman's office in Texas. I'm totally unaware, and I'm not in politics. So said the congressman is interested in introducing SHAPE guidelines, which at that time had just been published in Texas legislature. And I was very happy to hear that. I made a trip and found out, just like the movie said, in cardiology, everything has to be crisis before we get to it. This congressman had gone through a testing, wanted to get coronary testing, or CAT scan, heart scan, according to him. His insurance declined. About 2 weeks later, he experiences acute MI. Fortunately for him, he survived, but very upset about the insurance company. I don't know the insurance company. It was Cigna or one of those companies. So he was not happy. And so he hired 2 lawyers who write the bill and got help from SHAPE Group to fine-tune it. And we introduced it in 2000, I believe, 7. We passed the floor of House, but not the Senate. And we reintroduced it in 2009, and it was passed and became the first state to mandate preventive screening using coronary calcium as well as carotid plaque. And I'll tell you what we have on the screen is a light version of SHAPE. And we wanted to, I'm not a very politically correct person. These gentlemen are. They said, let's take a baby step to this population that is here. We show them the baby step. This is the baby step. The actual SHAPE guideline says, do it for those other people as well. Because if it's good for everybody. Yes, we tell the other guys to take a statin, but they don't, just Dr. Berman showed, they don't see the event. They don't see the disease. They are not very motivated. You told them cholesterol, their cholesterol is high. Some of them don't feel they won't take a statin. So why not just taking SHAPE as a full, not the diet version, and just go straight and tell people, if you don't have coronary calcium, you're not going to have a heart attack, 99.9% in the next 5 years. And then you can repeat it 5 years later. Just the dose of a mammogram. So it's not really a huge amount of X-ray. And if you do, get treated based on the severity of disease. If you are 1,000 or 2,000, you are a walking time bomb. And you're lucky you're alive. And a lot of you were not alive at that time. So I have this passion for this organization, and so don't want to take more time. SHAPE organization is shapesociety.org. I got to know Hattie, and she participated in our recent event in Los Angeles, which this slide was developed. And you're welcome to contact the congressman in Texas. And if you want to learn more about the state of Texas experience, I'll be happy to share with you.
Thanks, Mort. I'm Mike McConnell. I'm a cardiologist at Stanford. I've been doing imaging a bit over 20 years. I direct our cardiovascular MRI program, and I also co-direct preventive cardiology with Dr. Marin. I'm also proud to be on this panel, and thanks for Hattie's efforts to bring this all together and to also help Mort with the SHAPE program. So while I've done a lot of research on MRI and other technologies to look at vulnerable plaque and to try to identify patients at risk exactly for this purpose, clinically and from the great evidence that you've seen, coronary calcium has really emerged over the last couple of decades as an incredibly powerful tool. And I know you've heard from a lot of the other panelists. Probably the one extra piece of information I can share is that I have some intermediate risk factors, and I had my coronary calcium scan done last year. It's almost easier than getting a fasting blood test. I keep forgetting to fast to get my fasting lipids done. It's a very quick and easy test. And the cost is not too different from some of the blood tests that are done now. And actually, my Stanford insurance covered it. And I'm always excited to see the power of zero data up there because my score is still 0, and I'm working hard to keep it there. So.
Good morning. My name is Ian Rodgers. Thank you for the opportunity to be here. I'm a cardiologist at Stanford with Mike and David and Marianne. My area of expertise is in cardiovascular imaging, including cardiovascular computed tomography. I know we're out of time, so for sake of brevity, I'll echo wholeheartedly the sentiments that have been presented here this morning. Coronary artery calcium scoring is such a simple test, such a fast test, and makes so much sense. It allows us to very quickly, very easily say to a patient, you have disease, you don't have disease. Few other tests have that power, that clinical power, with such ease.
Thank you all very much for your introductions and I guess sort of testimonials. Hattie, if time permits, or I should ask Warren if time permits, because we did start late. Smart man. She's deferring, he's deferring to Hattie. It really wouldn't do justice to you if you didn't have a chance to ask questions. Alan?
Bruce Brundage gave me a score of 0 in the year 2002. When you say if you have a score of 0, we should reassess risk at 4 to 6 years. What's my likelihood of progressing beyond a score of 0 to something that's really meaningful? Has that been studied to say 0, are they still 0, how long do they stay 0?
Great question. Alan Ertl is asking. He says in 2002, Bruce Brundage did a scan and his score was 0. What's the evidence that that will convert?
So Dr. Brundage was my boss at the time, so I can attest to this. So the calcium scores, your chance of having a significant score increase over the next 5 years is very small. And that's where the 4 to 6 years that Dr. Marin put on the slide reflects the ACCHA guidelines for this when they talked about risk reassessment. That at 4 to 6 years, it's reasonable to see where you are because your blood pressure could have gone up, your cholesterol could have gone up. Some of us develop diabetes as we get older. Your risk of having an MI, and about 20%, thank you, and Dr. Berman reminded me, it's about a 20% of your conversion rate. So about 1 out of 5 people with a score of 0 will convert to a positive number over the next 4 to 6 years. But your risk of an event still remains low. So it's just a matter of if it's going to change your management, it's prudent to know if you're in that 20% group.
Okay. Yes, sir.
Yeah. Just 2 quick questions. One is, what about this argument that there's good calcification and bad calcification? So good calcification might be dense calcification, and it comes from the MESA study, and bad calcification is volume. And then my second question is related to this. Depending on which risk calculator you use, but they're all pretty similar, age is such a dominant factor that unfortunately if you get to be like my age, you really can't get below 7.5%. So that this is essentially universal screening for a big part of the population.
Okay. Thank you for those questions. And who wants to take the first one about good calcium, bad calcium?
Can I just clarify?
Yes.
So this, you mentioned that at a certain age you won't be below 7.5%. I think importantly, we're not advocating that group at this stage. We're not recommending that over 7.5% group automatically fall into the calcium scan group. So it's really targeting that intermediate risk group, which has been kind of the gray zone in the current guidelines and most consistent with all the prior recommendations.
So importantly, 100% of people your age and presumably your risk would be excluded from a calcium score. We're not talking about universal scanning, we're talking about universally not getting a scan. The 7.5% risk is universal statin treatment. So while Mort would like to change that, our guidelines would be concordant with the current guidelines that would say you deserve a statin and an aspirin if you're above 7.5%, and there's no utility of a calcium score. Very important.
I could just add to that it's your choice. You want to pay $700 and buy an iPhone, or pay $80 and know if you have plaque or not, or continue to take a statin blindly, or that's your choice. But we would like to tell you that.
The word screening there applied to just being evaluated for risk. The screening was not for screening using coronary calcium scanning. There was a weeding out of the people who wouldn't need the calcium scan, down to that very small group of the 5 to 7.5% group. I would point out this is a very conservative algorithm because we saw that in the over 7.5% group, in the group where statins would be recommended, 41% of those patients had a 0 score in the appropriate age group. And in those patients, appropriate treatment would be not recommending the aggressive treatment.
Those were great answers to your to the first, to the second question. And I'll just point out, which I didn't point out when I went through the slide, that 50% of coronary events occur in the group that has a risk of less than 7.5%, where this screening would be most valuable, I think. Now, yes, good plaque, bad plaque, Mike Cricky.
Sure. What we're realizing, there's a lot more information in the calcium scan as well as in CT angiograms than just the score tells us. So if you have one big dense plaque in your left anterior descending, it's probably been there forever, and if that's the only plaque, you're probably safe. If you have the same score, but smaller, less dense plaques in multiple vessels, you're probably at higher risk. And we're working on how to score this better. But the calcium does show the whole history of what's happened. You know, when you do a algorithm just when you're age 50 or 55, that's one point in time. And what matters is the accumulation of dose of LDL and other risk factors over time. And that's really there in the imaging, but we have to learn how to tweak it out a little bit better.
Just to add to that point, it's not that the calcium itself is going to be the area in which you're going to get the heart attack. The calcium score, which looks at the entire coronary tree, is the best overall estimate of the atherosclerosis burden. The amount of calcified plaque you have is related to the overall amount of plaque you have, including the non-calcified or soft plaques, where the rupture of plaque is more likely to occur.
So I'm going to take the privilege, before I ask Dr. Bertozzi to ask his question or make a comment, staying with this point, I'm asking the panel, is calcium itself just a marker of atherosclerosis, or is it implicated in producing events? Is it a culprit, or is it just a bystander?
Let me say that the best, it's a marker, it's a bystander, but we know it's people with a lot of bystanding plaques that are more likely to have an event. And what we're realizing now is the flow through the coronary, what we call the rheology. We know events, atherosclerosis occurs where you have branching, where the coronary or other arteries branch, and that's where you lay down new plaque. And the more lumpy and bumpy your coronary is, that does increase your risk for laying down more plaque. So you won't, calcified plaque's not where you're going to have the heart attack, but it creates risk in several ways.
Thank you. Dr. Bertozzi.
I found the evidence presented to be very compelling, with one exception, and that is that the cost data was presented about the cost results for a trial, but the implication was that we would see those same cost results if we scaled it up to the population. And I don't think we know what would happen if we scaled up to the population, but we have one small trial that is concerning. It was done on November 5th of this year with 70 cardiovascular disease experts, and we asked them what would they do with a high calcium score, and 41% of them said they would send the patient for cardiac cath. And so that suggests that what we would see in the population might not reflect what you've seen in the trials. So I think that as we think about scaling up, we need to think about that very carefully. The good thing is that one of the best places to think about it is where there's positive control of the provider behavior, and that's the health plans in the Right Care Initiative. So it'd be a great place to start.
So let me just, so I completely agree. I think with any new test or newer test introduced to a group, obviously they're not very educated on the utility of the test or how to use it properly. We need to have, guidelines and accompanying information about what the test means and what the next step should be. A cardiac cath is clearly inappropriate. We looked at a population-based sample in MESA. It was not a controlled trial. It was just a scan done, and then they're just observed for the next 15 years, free. They go back to their primary doctor. There was cost. There was no net increase in invasive angiography use over the trial based on the calcium scoring. We've looked at this. There's a cost paper published in a journal called PLOS ONE in 2015. It was very, very cost effective compared to just standard screening because of the zeros downplaying the need for some of the therapies. But I agree with you. We need to be very careful when you have a score, but luckily all of the reports come with a guideline. So if I go to Dr. Berman's site at Cedars and get a scan, it tells me, based on my report, what the current recommendations are, and none of them say, go get a cardiac cath with your cardiologist, but we do need education in that regard.
One burning question here. I'm from the slow school, Berkeley, but it seems to me, as a consumer advocate, that in the case, Dr. Burdock, I'm from the slow school, I'm the consumer advocate. Mayor, seems to me that if this test is this cheap, and in the case of Blue Shield, question Dr. Burdoff, have you tried filing a lawsuit? Have you tried going to Elizabeth saying this is cheap, I have cardiac problems, cholesterol problems, et cetera, what have you tried to do to get Blue Shield to do the testing?
First, I'd like
Or
to
is
know if
this
they're
a-
here. Are they here before I answer? No, okay. All right, well, I don't want to, no, I'm kidding.
Okay, Blue Shield
I'm
is
kidding,
here.
I'm kidding. I'm kidding.
Target.
All we've done is talk to the insurance commissioner who said he didn't have power. Hattie obviously has better answers on what people can do and what patients can do. We have not tried filing a lawsuit. We are hoping to resolve this with education rather than litigation. But
File 24 lawsuits, want a suit, we'll get your pro bono lawyer. Change behavior.
well, I'll talk to Blue Shield over lunch, and if we don't come to some good conclusion, I'll talk to you after.
We're trying behavioral economics first, right?
Process in California state law that's quite protective of consumer rights. And when a test is scientifically appropriate, we have a process for ensuring that. The problem is most of the cardiologists here did not know about that, which indicates that most cardiologists in the state don't know that if they're trying to get a test for a patient and it's being denied by a health plan, there is a scientific process for determining that. And Beth Abbott here, the California patient advocate, and Mary Watanabe can give you more details. You have cards on your table. They're, what color are they? They're green and blue. That list are, if you just look at the Department of Managed Healthcare website, there is a process for getting a test approved when they're medically appropriate and scientifically appropriate.
Can I just make a quick comment on the last 2 points, which in my experience, when we call insurers and ask about non-invasive testing, we often hear, why don't you just get an invasive coronary angiogram as the response, as a much more high-risk, expensive, and I think less informative test. So I think what you may be experiencing from cardiologists' response about ordering invasive tests is that's actually partially being driven by the insurance companies, ironically.
I was just going to follow on with a question. How do we deal with Don Berwick's medical industrial complex? Because we have vested interests. A lot of money in the economy is made with pharmaceuticals that sometimes are overpriced. We have self-serving interventional cardiologists and cardiac surgeons. Their patients believe they are gods or goddesses, and it's hard to change the culture and the knowledge and wisdom in the country. It took 130 years for vitamin C to be recognized as a cure for scurvy. Let's do a little better this time round.
Thank you. Who would like to respond?
Well, I think this falls under SHAPE as a grassroots organization. I think eventually movements like what Mike is doing with his app and Apple would bring this kind of knowledge and democratize it to, that's what we need to do. What we had here, I don't know how many of you knew about this, but I suspect a lot of you were not aware of the latest evidence. If we are able to do this in a mass level and people see and download the app and see the evidence, I think that's where the gate will open and that 130 years will be hopefully, less than.
Yeah, I mean, I think we're all still very strong advocates for the earliest we can help people with lifestyle changes. I think, the data that we're seeing from San Diego, the efforts of the SHAPE program, and I think a greater awareness of emphasizing health and wellness earlier that is being driven by communities and companies and more insurers, I think is critically important so that hopefully we can all stay zero.
I want to add one more comment, because when I told this in our meeting and had a knee-jerk reaction, and that's the stress testing. It is so overly done. A lot of physicians, just as soon as a patient says, I have something and so on, or a little chest discomfort, they can easily write a stress testing, and they write the code easily. And most of you payers don't have any way to fight that. So if you look at it, we did a cost-effective analysis in comparison and showed that a test like coronary calcium obviously brings more information, because the stress testing, some of you might know, you have to have more than 75% narrowing in the coronary in order for stress testing to come out positive. And when it is positive, it is false positive in particularly women and certain populations. So whereas here, there's no positive calcium score as a false positive. There's no place for bone in your heart that calcium is. So once you see it, it's disease. And I hope that this comparison, and I told her about Bill Clinton, presidential care, he got a stress testing the year before, every year as a presidential. He didn't know about, or his team didn't know about coronary calcium. A year later, he walked into ER with chest pain. And so it's something that we need to go after and change behavior and habit. And what David did with Courage Trial, teach people it's not a plumber thing. You go and open it. You just need to get your medications and lifestyle modification and so on to treat the disease.
This is Dr. Jeff Mason from United. I think we can take just one more question, and then we need to move on to our discussion before he needs to dash for a plane to Florida.
Yeah, this will just take a second. This is very interesting, and although I had heard a little bit about the coronary calcification, you're right that I wasn't aware of the powerful evidence behind it. However, and this may seem a little cold, the comparison is going to be between treating everybody with intermediate risk with a statin and aspirin versus doing this study to find out who really has the disease in that subpopulation. And I think the real economic issue is what is the return on investment for this versus treating everybody with a statin. And I'd be interested to know if that calculation's been done.
I'd be glad to share that with you. So the question was about treat all versus calcium scoring. The PLOS One paper by Dr. Roberts, first authored, used the MESA population as his model and found that calcium scoring is much more likely, 75% likely to be more cost effective across any range of care versus treat all. So it was about 4 times more likely to be a cost effective strategy. Obviously, you have to put in a lot of assumptions into those things, but that paper I think is very well done, and I think it'll show you it's cheaper to treat selectively than to treat all.
Yeah, I think that's a strong argument that the health plan should pay attention to, but the argument that we just heard about what doctors are really going to do with this information, that's scary and real.
I just want to say we've heard that fear before. We've never, ever, and I've tried, we've never been able to validate the concept that a high calcium score drives a lot of cardiac caths. I think that's a concept by doctors, but it's deemed inappropriate to do a cath in an asymptomatic person. And I think the healthcare industry, the payers have to tell doctors when it's inappropriate.
I'll speak for United. We have put guidelines in place for cardiac testing, including elective coronary angiography. And it would be denied at United if somebody requested it.
So hopefully those safeguards will help us keep it appropriate.
A comment?
I think everybody heard it, but I'll say it again, okay? We have guidelines that United Healthcare has put in for our populations that call for prior authorization for elective cardiac procedures, including cardiac catheterization. And we use evidence-based guidelines, and there is no evidence-based guideline that says that you should do cardiac catheterizations on asymptomatic patients regardless of whether they have calcium or not.
Thank you. A comment, real quick question, and then Dr. Agatston. The comment, Matt, could you please send that paper to Hattie, who can forward it to United Healthcare?
And anybody who wants it. Right.
Okay. Okay, and is Dr. Bertozzi still in the room? No. I believe that the data, the survey he was referring to, where 41% referred to cath, is you. And so how many of you actively practice cardiology and see patients? A couple. Okay, so the point made. We're not talking about what a cardiologist would do. I don't think 41% would refer that asymptomatic patient for cardiac catheterization. Without further ado, Dr. Arthur Agatston.
Thank you, David. It's really a pleasure to be here and meeting the Right Care group, and met Hattie yesterday, who truly is a force of nature, and adjusted my talk a little bit. I'm sure made it better, and Warren and the whole group that's done Right Care, and heart attacks are absolutely preventable if you start early enough. With kids, it's preventable with lifestyle alone. We actually did a study called the HOPS trial, Healthy Options in Public Schools, where we decreased weight and risk factors in kids. But the main thing was when you start young, they accept lifestyles. So it's just getting the word out there, and what Dr. DeMari has done in San Diego just shows we know what to do. We just have to get all the practitioners to do it. And what we are going to do is talk about lifestyle and put it in a context. Here we go. This is a book my parents gave me to read back in 1970, Future Shock. And Alvin Toffler said that in 3 short decades between now and the 21st century, millions of ordinary psychologically normal people will face an abrupt collision with the future. That certainly happened. We see all this data about the number of people taking pills, and it's the acceleration of technology that's changed risk factors, behavior risk factors, and many others. But really the march of technology started a lot earlier, but it's important to understand where we started to understand where we are now. And really our DNA was designed to survive in the wild, and that was the hunter-gatherers who roamed the earth for 400,000 years in small tribes. They had to spend all their time hunting and gathering food. They didn't have any time really to invent things, and there was really no progress made. And then it was 10,000 years ago where the agricultural revolution started, and things started moving forward in our lifestyles and the way we lived. Then the Industrial Revolution.